Hello, I am Dorina Landa, and I'm the Executive Director of Advancement at the University of Toronto's Temerty Faculty of Medicine. And I also have the distinct privilege of serving as the university's Assistant Vice President for Advancement Relations with Healthcare Institutions. Before we begin, I'd like to take a moment to acknowledge the land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful for the opportunity to work on this land. And it is my great pleasure to welcome you all to this latest event in our Temerty Medicine Talks series. This installment marks a special milestone. It's the 5th anniversary of the series, which was launched in October 2020, shortly after the announcement of James and Louise Temerty's historic $250 million donation to our faculty. That extraordinary gift, the largest to any university in Canadian history, has accelerated discovery, collaboration, education, and innovation across Temerty Medicine and our network of partner hospitals. We launched the Temerty Medicine Talk series as an opportunity to spotlight the many ways our researchers and clinicians are advancing health and healthcare here in Toronto, across Canada, and around the world. So thank you for joining us today, where we'll be discussing the latest developments in breast cancer surgery, education, and care, and how Toronto researchers are collaborating to advance these efforts. I hope you enjoy today's discussion, and I certainly look forward to welcoming you to more Temerty Medicine Talks in the future. I'd now like to turn it over to Dr. Lisa Robinson, Dean of the Temerty Faculty of Medicine, to say a few words.
Thank you, Dorina. It is my sincere pleasure to welcome you to this Temerty Medicine Talk. As many of you know, the University of Toronto and the Temerty Faculty of Medicine are the hub of Toronto's world-renowned academic health sciences network. This network of clinicians, researchers, educators, and learners on campus and in our affiliated hospitals and research institutes work collaboratively to develop innovative solutions to medicine's biggest challenges. In today's Temerty Medicine Talk, we will highlight a shining example of this approach. I'm proud and excited for you to hear from 4 Temerty Medicine faculty members on how their work is advancing education and research and promoting breast cancer surgical care. It's an especially fitting topic at this time of year, as October marks Breast Cancer Awareness Month. I am also so pleased to have renowned Canadian journalist Wendy Mesley with us to guide today's conversation. Wendy, thank you for being with us. I'm going to turn it over to you now to further introduce today's topic and speakers.
Thanks so much, Lisa. I'm Wendy Mesley. It's amazing to be here and with all of you for this Temerty Medicine Talk on advancing breast cancer care through the Toronto Breast Surgery Collaborative. I only wish it had been around when I was first diagnosed almost 20 years ago. So yes, I'm a breast cancer survivor. I can tell you that a diagnosis, it launches what can be completely overwhelming. It can be scary even. A lot of progress has been made in our understanding of breast cancer, and many patients, like me, go on to remission, recovery, but fear of the disease is not entirely misplaced. Breast cancer is still the second leading cause of cancer death among Canadian women. And so there are lucky and unlucky people, but there's lots of good news too. There's a group of surgeons steadfastly working together across the U of T network of affiliated hospitals, and they're all working on seeking better outcomes. And today we have 4 esteemed members of the Toronto Breast Surgery Collaborative. They are also surgeons, they're breast cancer surgeons, and they're here to share more about the state of breast cancer care today, recent progress, what gaps remain, and how the collaborative is working to drive that change. You may all already know, but I want to know, how exactly does the collaborative work? And so you can see their full bios in the description below, but let me briefly introduce them now. First, we have Tulin Cil. She is an associate professor of surgery at U of T. She's co-founder of the Toronto Breast Surgery Collaborative. as well as a surgical oncologist at the University of Health Network's Princess Margaret Cancer Centre. We also have David Lim. He is an assistant professor of surgery and the research director of U of T's Breast Surgical Oncology Fellowship Program, as well as a breast surgical oncologist at Women's College. Next is Fahima Osman. She is an assistant professor of surgery at U of T, as well as a breast surgical oncologist and surgeon investigator in entrepreneurship and innovation at Women's College. Finally, we have Amanda Roberts. She is an assistant professor of surgery at U of T. She's also co-founder and director of the Toronto Breast Surgery Collaborative, as well as the program director of U of T's Breast Surgical Oncology Fellowship and a breast surgical oncologist with Sunnybrook, the Sunnybrook Health Sciences Center's Odette Cancer Program. And then there's me. I hate to say it, but I was treated for breast cancer at all three hospitals. Princess Margaret, of course, Sunnybrook, Women's College, and my mom wishes that I'd gone to U of T, but I didn't. Anyway, thank you so much for joining me today. They might all be doctors, they might all be surgeons, but I'm going to call them by their first name, and we agreed that I could. So, Amanda, you started the collaborative. It's your brainchild. What is it? What does it do?
A great question. Well, it originally started in 2014, actually. The idea came to me when I was a fellow and in training. And we go between the sites, and I realized that there was not a lot of collaboration amongst the sites for research and education, actually. We didn't have a real good forum for the breast fellows. So I did bring the idea forward to bring the breast surgeons from across the city together. And a lot of people said no one would come, actually. But Tulin Cil believed in this idea, and she hosted the first meeting at her house, and everybody came. Even the people who said no one would come came. So there was obviously a need and a want. And from there, we continued to bring breast surgeons from across the city who treated breast cancer together. We did at least 3 meetings a year, which we still do. And this really provides a space for knowledge translation amongst the surgeons, a space for updates on clinical evidence, educational opportunities and networking opportunities for our fellows and trainees, and also a space for research collaboration with the ultimate goal of improving patient care.
So you talk about the need. What is the need?
Well, breast cancer is a fast-changing field. There's studies every year that are practice-changing. There's lots of uptake with new evidence, and a lot of surgeons across the city and province treat breast cancer. A lot of us, that's all we treat, but a lot of surgeons treat colon cancer, treat other cancers, and to keep up to date, it's challenging. So I think the need to keep up to date and to also feel that you have a community that you can turn to for advice or, as I said, collaboration with education and research is where the need was.
So, Tulin, you're the co-founder of the collaborative, and you set up a boat, which we can get into. Or do you want to follow up on Amanda? Like that first meeting at your house, it sounds like it was quite something.
Thanks. It was an exciting opportunity, I think, to bring everybody together from across the city. You know, I think we often work in a little bit of a siloed environment at different institutions, and to come together and really share the research endeavors that we're doing, the knowledge that's coming through knowledge translation, and the education aspects were really important to all of the surgeons, not only the teaching institutions, but across the community hospitals as well. So it was an important initiative from Amanda as brainchild, and I'm really happy that we've been able to continue it on for the last decade, really.
And now you set up something called ABODE. Tell us about that.
Yeah, so the ABODE study is really an acronym for at-home breast oncology care through digital means and digital education. And it really came out of the COVID timeframe where, you know, we did see that there was a huge uptake in virtual care. And this was important for us to be able to take care of patients. But I think, as we know, there's a tremendous need for really good, high-quality patient education that's tailored to the patient at the appropriate time in their treatment. We know that people can find a number of different things online, and a lot of them might be good, but a lot of them might not be helpful for the patient at that point in their cancer journey. So our goal really with Abode was to create an app where patients could have access to this high quality vetted patient information, where they could get some support from their care team through instant messaging, because it's a virtual platform that will allow that, to get peer support from our Care and Connect team through Princess Margaret, and to really follow the patient for the whole year after that breast cancer diagnosis. Which contains so many different parts of treatment, right? It's the surgery, it's the radiation, it's the endocrine therapy after, the survivorship period has its own challenges. So, we wanted to bring that all together, create this app, which we're really lucky to do with funding support. And we're now studying it to see how our patients do when they have access to this kind of support.
Wow, you talk about breaking down the silos. I think at CBC was 20 years, I think. I was there longer than 20 years, but 20 years they talked about we have to break down the silos. But of course, everybody has their own particular approach to a silo. But I also wanted to pick up on the digital aspect of what you do. Fahima does that too. I'll talk to her about that in a moment. But I'm very wondered about, I do very wonder about Dr. Google, because you mentioned online. Everybody, I remember all of the doctors or all of the surgeons when I was first diagnosed saying, do not go on Dr. Google, do not go on Dr. Google. Of course, everybody does. Is that bad?
No, I don't think it's bad. Certainly, our patients are very motivated to get the best information around their care, right? And that's a good thing, to come into your visits with that background knowledge. There are very good sites which will prepare patients for their doctor visits and their treatments. I think, though, that the danger comes when people see things that may not be applicable to them, because breast cancer is such a heterogeneous disease. It's not a one-size-fits-all treatment, especially now with the research information we have and how we're really personalizing breast cancer care for the specific type of breast tumors, the patient's stage, the patient's other medical issues. So all that really is a very complex decision-making process. So it's hard to read about one treatment and to really say if it does apply to them or not. And that's where shared decision-making comes in with your healthcare providers.
Yeah. So Fahima, I'm just wondering, Dr. Osmond, I'm just wondering, is it no longer one size fits all? How does the collaborative reach out to people? What is the digital approach?
Yeah. So I would say I was actually motivated by not being a fan of Dr. Google, and basically, as Tulin mentioned, that it's not one size fits all. I find breast cancer to be different types of breast cancers, and women, it can hit them at different stages in their lives. In retirement, and when you're planning a new career or having young children. So it has to be it's a customized journey for each patient. And as you know, how overwhelming it is, Wendy, being a cancer survivor and going through that journey, it is quite overwhelming. So the motivation, and we were very incredibly fortunate to build also a platform for both patients and the clinical team, was to help them navigate cancer, because it is overwhelming, not only for patients, but also for us as well. It's hard to keep up with when patients are in chemotherapy versus radiation, and also how they're doing in survivorship. So the opportunity that we had was build a platform that integrated with our hospital health information system and collected that data, and also helped the nursing team as well as oncology to see where patients are in their journey, so we can better support them with educational content. But what I was fortunate to see see was that we need the data to help us improve the quality of care that we're giving. And I find what makes it really challenging is that, of course, operating in silos, not having access to that data. So we built it in also motivation to get that data in an easy way so that it's accessible to all and not just the healthcare team, but also to patients.
So it's okay because we're all going to go on Dr. Google. I hate to tell you that we are all going to go on, but through the collaborative, you have other information that hopefully you're hoping will have more of an impact. Right.
And I was practicing in the community for several years, more than a decade, and I found the collaborative to be valuable, quite valuable, because at that time I was concentrating on, I didn't have a focus in breast cancer alone, and as most community surgeons, you have basically different types of practices from emergency surgery and different cancer sites. So it's hard to keep up. As Amanda mentioned, there's a practice-changing trial every year, and having the collaborative is a safe place where you meet in an informal way, and you have experts like Tulin, Amanda, and David that would synthesize the literature and discuss basically the practice-changing trials, and allow us in terms of the community to have that area of to get that experts take on this literature. So it's a great place to have knowledge translation, especially from as a community surgeon perspective, because having the time and having that focus of just a breast cancer is I would say a luxury, which now I'm appreciating actually since I've now switched to Women's College Hospital.
So, David, it's really interesting. I have a friend who is, the cancer may be back, maybe. We hope it's not back. And so she said, let's just take all of them off. Just the whole idea of the lumpectomy versus the mastectomy versus the reconstruction. There's more and more people. I think your interest is primarily in research, David. But more and more people are leaning towards no reconstruction. Like, what are you learning?
Well, we definitely were for some time seeing that women were choosing to have mastectomy over breast conserving surgery, despite the fact that both surgical options really do give the same cancer outcomes, like survival and rates of recurrence. And we saw that a lot of it was driven by fear. So I think it's important when patients are meeting with the surgeon to have that discussion to talk about the outcomes. One thing they may not appreciate is after the surgery, all the psychosocial impacts that may come with that. And certainly with having mastectomy, that they often go in hand together with having immediate reconstruction at the same time. But we are seeing more and more women who are now happy with going flat, as well as there's a big movement called the going flat movement. And we know, we've heard that some patients aren't given that option. It's either having double mastectomies and having reconstruction or going with lumpectomies. And so more and more we're trying to let patients know that it is a viable option, and patients are satisfied for those who choose to go flat and have a flat aesthetic closure.
It's really interesting that it's that the research shows that people are not so hung up on having a chest anymore. But does the collaborative allow you to do that kind of research?
Well, I think there's a significant potential in the collaborative in potentially doing that. During my time as a fellow, we looked at that patient-reported outcome data that the breast surgical group and the plastic surgeons were collecting at University Health Network, and we were able to find that the patients who had breast conserving surgery had the better patient-reported outcomes. And those are important data that you can take back to the patient and talk about that during counseling. But of course, that's only one site. And we know that at University Health Network, the patients are highly motivated, highly educated. A lot of them are Caucasian. And I think the collaborative would be ripe to study patient-reported outcomes, looking at multiple centers across the collaborative. And we know that each center has their own niche, and we see that others see more marginalized women. I think we need to learn more about patient-reported outcomes in those women And at some sites, they may not have access to immediate reconstruction as well as others. So I think it's important to look at patient-reported outcomes across different settings and across different patient populations. And that's one of the potential that the collaborative could meet.
Okay, and not yet. We're going to talk about dreams and hopes down the road. But yeah, I just find it really interesting because do you talk to women 5 years or 10 years after too? Because there's a very different view on going flat or having a mastectomy or not, or reconstruction down the road.
So there's actually, I would say, a positive data in that space of patient-recorded outcomes 5 and 10 years down the road. Because often once they're finished breast cancer treatment, we often discharge patients back to their family doctors, or for some of them are followed in a survivorship clinic for a few years. And so that's an area that we need more data on as well.
Yeah, so Amanda, I'll come back to you if that's okay. There's all this talk about breaking down silos, and but you know, at CBC, everyone just kept doing their thing. For eventually, there was progress that was made. Is the collaborative working? I mean, it's all data. I spent my career in communications, which is data. Is it working? Are you getting somewhere?
Over the last decade, I think we've done a really great job with our knowledge translation and with our education space. We have expanded to many sites. Even though we're called the Toronto Breast Surgery Collaborative, we have attendees and members from actually across the country and across the world. Our previous fellows who are working internationally still attend our Zoom meetings. So in that space, I feel that it is working. I think we're doing a really great job in those two pillars. The space of research is, as David said, the space that has the most potential and where we have the most opportunity. We currently, it is a space where people can share clinical trials between the sites, where they can send surveys to gain data from the surgeons. And we do have a small group that's doing some research using administrative database. So we're collaborating on making sure we're not overlapping in those research projects. So little by little, I think the research part is working, but it is the space that really there's the largest opportunity to do a lot more.
So David, you mentioned the fear. One of the fears is of saying goodbye. I remember when my doctor, I think I had 4 doctors and they were all breast cancer oncologists or whatever. But one of them was the main surgeon, and he said, "Okay, well, it's been 5 years. You're off the drugs. You're off the whatever. Bye-bye." And I was like, "What? It's over?" So David, is that one of the fears of actually saying goodbye?
I think patients tend to form very strong relationships with their medical providers while they're receiving active treatment. And I feel that once active treatment has been completed, a huge weight has been lifted off their shoulders, and they often wonder what's next. And the person that they've always been falling upon for support and has been part of that journey is their surgeon. And so I think saying goodbye has that effect.
Is that something that you're looking at the collaborative, or?
Well, I know that we all have interest in survivorship, and survivorship care is part of that. It's not simply about looking out for recurrences or new breast cancers, but also to help patients get back to return to work, get back to exactly improve their psychosocial well-being. And we know that breast cancer care and treatment doesn't end after active treatment. There's a whole continuum with survivorship. And so I think helping to really support patients at that stage will help prepare them for moving on from the surgeon's office and their care. So
Fahima, I just wanted to pick up on something that you said earlier about working in community hospitals and helping patients in remote communities. It's different, isn't it? It seems different.
Yeah.
Your 3 Toronto hospitals, you represent that it's great if you get, it's great, says the person who has had cancer. But it's better to have it in Toronto. What happens if you're in a remote community?
Yeah, that's a great question, Wendy. It's we're very privileged to be here in Toronto, where you have basically radiation center across the street, and you have also medical oncology and other subspecialists. But when you're in a rural community, the nearest radiation center would be 500 kilometers away, and that does impact the decisions that patients make over there and their families in regards to whether they will the type of surgeries that they would choose, and also that would impact also the way that they have to interact with the healthcare system. So there are different decisions made in rural communities compared to being in a big city in Toronto, where there's all the treatment centers are close by together. But our government does as much as possible to support them in terms of travel grants and to seek care. But it is a big inconvenience to for family members as well to travel to big cities and do those treatments that can last for several weeks, actually, and spend that time away from home.
David, I want to bring you back in here. I'm having a flashback. It was 20 years ago. It was sort of the dawn of Herceptin had just been discovered. It wasn't yet paid for, and it was paid for just in time for me. Thank goodness. Sentinel node surgery was had just been developed. What's the newest research now that the collaborative is looking at?
I think we all have an interest in disparities in accessing care and treatment outcomes. We know that overall we're getting better and better at screening. We have better treatments for breast cancer, and we're better at treating breast cancer, but there still remains some groups where we don't seem to understand as well, or they simply continue to have worse outcomes, such as marginalized women, Black women, specific subtypes of breast cancer. And so I think that's where a lot of research has focused on. We also know that a lot of treatments, or we've gotten so good at treating breast cancer, we know that a lot of sometimes we're probably treating more than we need to. And so there's a lot of focus on trying to de-escalate the amount of surgery or the amount of radiation or the types of medical treatments we need to give. So that's a significant focus of research right now as well.
So some of it actually isn't needed. You're scaling back.
In the right amounts, carefully scaling back cautiously.
So Tulin and Amanda, feel free to pop in, but what could you do more? Like, what are the gaps? What is the dream for the collaborative?
Yeah, I think I just wanted to add to what David was saying. I think one of the things that we've seen as surgeons is sort of progress in some of the surgical techniques. And, you'll hear the term oncoplastics. We're looking at more minimally invasive ways to do mastectomies through either endoscopic or robotic means. So these are all exciting innovations. And I think having a collaborative like ours is enabled us to talk about these kind of approaches from a surgical perspective too. So again, that knowledge translation has been really key. I think the dream, as Amanda alluded to, would be to really get that patient level data from a research perspective. We have an amazing data set across Ontario through ICES, so the Institute for Collaborative Evaluative Sciences. And it gives high level data. All of us have done research with those data sets. But we can recognize the limitation of that data when you really want to tell your patient exactly what might happen to you based on the features of the disease as we're seeing it. So I think that patient level data across our institutions and really harnessing that is sort of the ultimate goal if we aim to something for the collaborative in the next several years.
Amanda?
Exactly. That in the initial vision statement for the collaborative, that was the final statement, to have a network of data across the centers. And as David mentioned, with the volume and the diversity of the patient population in the Toronto area and beyond, if we had the financial means to leverage the infrastructure that's already there, actually, to pull all this data together and look at those patient level outcomes, as Tulin said, to tell a specific patient what their outcomes are going to be at their age, with their cancer, with their treatments, the impact that we can have on patient care would really be unparalleled in Canada. It would be amazing. And that was the ultimate dream for the collaborative, and that still is our ultimate dream.
So I really just have one question. What on earth is oncoplastic? Does that mean making things out of plastic?
It's actually the use of plastic surgery techniques in the oncology space. So doing our oncology surgery using plastic surgery techniques so that patients can improve the cosmetic outcomes. As we know, they live a long time and we want them to be happy with their cosmetic results.
So, David, I think you specialize in lobular cancer. I was amazed. So I had two kinds of cancer, and lobular was the second kind that was found, by the by. But I just read that it's David, that it's more deadly. It's hard to detect, and it's more deadly. Ooh! So tell me more. What have you learned?
Well, we know that lobular is trickier to detect because in lobular breast cancer, what distinguishes it is that the cells have lost the ability to stick together. So when the cells are growing in the breast and they're not sticking together, they don't form a solid mass like we see with the more common ductal type. It also makes it harder to detect on mammograms if you don't see a mass and you don't feel a mass either. And so patients often can have large tumors and it's hard to detect with imaging, with mammogram and on palpation. The thing about lobulars with survival is that they tend to have late recurrences, like after 5 years. And that's usually the time where they're no longer on their hormonal treatments. And that's the tricky thing, is that we don't have a way of really detecting when these late recurrences are happening. I think when it comes to like the lower stage tumor, maybe stage 1, there probably is no difference between lobular and ductal. But when you're looking at the more advanced stages, we do know from the newer research that's coming out that the lobulars have more late recurrences, and they tend to be more unusual sites than we usually see with ductal tumors as well.
So that's something that is shared. Like your research is shared with the collaborative. It's shared obviously with your cohort, but it's a much wider group.
So I have been funded by CIHR to look at a cohort of patients of lobular, and we're trying to target those higher stage patients to see if there's something special about their tumors that can make us predict why they're recurring. And so, of course, Sunnybrook and University Health Network and Women's are part of that network. And there's an opportunity to include other sites in the network as well. And so, of course, the collaborative is ripe for multi-center collaborative research like that.
So, Amanda and Tulin, feel free to pop in here. I'm just like, what have you learned from the collaborative? Amanda.
Well, I've learned that it's still a need and it's still a want, that our events are still highly attended and there's a lot of positive feedback. So what I've learned is that we need to keep going and there's still so much to do as a group. So that would be my take on what I've learned, is that we need to keep going. We need to keep expanding all aspects, education, knowledge translation, and our research component, because I think that we have a great group of dedicated surgeons and we keep growing, and we want to keep providing them with this opportunity to get together and share ideas and knowledge.
So, Tulin, I guess it's been a few years since everyone got together in your living room. But what would you do if you got more money? Like, I guess it's a follow-up. It's the same question as I'm asking Amanda. What have you learned, and where would your money go now?
I think the collaborative is the best way to break down the silos in care that we see working across all these different institutions. And as everyone alluded to, breast cancer is one of those diseases where the knowledge is changing rapidly. Things we even did a few years ago, the approaches we had, who gets chemo first versus surgery first, for example. I know Amanda's doing research on this. These are things that are evolving all the time. And I think to be able to share that information, to be able to harness the relationships we have at each of the sites with all of the surgeons, and to foster such a great network of dedicated surgical colleagues has been the most rewarding thing about the collaborative from my point of view. And I think we've learned that people want to be part of it, to want to contribute to the knowledge. And so we've really set up a great infrastructure. I think other groups have wanted to emulate some of what the Toronto Breast Surgery Collaborative has been doing in its mission. But from our point of view, if we had the funding that we would need to be able to get that research aspect really up and running to the degree where we could get that patient level data at each of the sites, and be able to really help all the surgeons that are taking care of patients at a multitude of hospitals. I think that's really where we want to be in the next 5 years.
So Amanda, I guess maybe it's a journalist's favorite question. What are the gaps?
I feel like a little bit of a broken record, but it is that gap in research data. That's the gap. I think we have all the other pieces. We have the engagement, we have the interest, we have the ideas. The gap is getting the data together. It's really hard to do data sharing amongst our centers. I think people will be very surprised to know that the time and the effort and the paperwork that it takes just to even collect data from Sunnybrook and UHN and put that data together, it's so hard. And that's why we haven't been able to do it to the level that we want to be able to do it. And that's the gap. And that's where if we bridge that gap, we will help not only the patients, but also surgeons, because there's a lot of quality improvement aspect that you can gain from putting that data together. You can look at margin positivity rates, reoperation rates. You can look at if you're sending enough patients to get neoadjuvant chemotherapy as part of standard of care. So there's lots of aspects to collecting that data that would be helpful for not only the patients, but also the surgeons and everyone involved. So that same answer, but a different spin.
Yeah, well, I guess it's the old joke is slash, burn, and poison, and you're still slashing, burning, and poisoning. But there are a lot of different answers, and I, like even in the 20 years that I've been alive since my cancer diagnosis, there has been so much change. I remember, I know people, they're ancient, of course, but who they had lymphedema from in the arms, and then that was before sentinel lymph node surgery. So there has been a lot of change, and anyway, I think it's all good. It's all sharing and all education, and it's all important. So I guess that's it. I guess we're going to conclude. I would like to say thank you to everyone who's been part of this Temerty Medicine Talk. Education and sharing matter. So thanks again to Tulin Cil, David Lim, Fahima Osman, Amanda Roberts. And for those watching live, you will see a link to a brief survey in the chat window. We would like everyone to make suggestions, all of them positive, of course, and to provide us with feedback on today's event. So thank you, all of you. And thanks again for joining us. Bye.